All right, so we're going to wrap up the semester with our discussion of the future of the health system. So this lecture is meant to go as a supplement, as usual, to your chapter. And this weekend, as I was thinking about this lecture, I was looking at my Wall Street Journal and I saw this headline about China considers lifting all childbirth restrictions by 2025. So in case you aren't aware, for several decades, the Chinese Communist Party, which rules China, had a one-child policy. And so families were not allowed to have more than one child. What does this do? Well, this naturally creates a declining population. And their thought was, we have too many people. And so one way for us to be wealthier is to have fewer people. And now they're realizing that maybe that wasn't such a great idea because their population looks something like this. And so you can see they have a aging population. So they have relative to, they have kind of a big fat middle here of people ranging from kind of their mid to late 20s up through to their, late 50s, early 60s. And this is going to be a challenging demographic problem for them because as this fat middle ages out of the workforce and continues to live longer, it's going to require more long-term care. But they're not alone. This is the United States demographic profile, which is a little better than China's, but not much, right? We're obviously not as many people, so the numbers down below are dramatically different, right? So China has about 4 times as many people as the United States. So not as many people, but more evenly distributed, but following a similar pattern to China. And we don't have a one-child policy, and China has lifted the one-child policy. I think they now can have 2 children, but now they're thinking about lifting it altogether. But really what we're seeing for the first time in human history, really, are these populations being shaped like this. And it is traditionally, it would have been much more of a pyramid, right? And the result is people naturally have fewer children as they become more wealthy. And as they become wealthier, they wait longer to have children. So the average age of the first child in the United States now is for women is like in the late 20s. And so there are fewer children born. They're born to older parents. And so what we see is a kind of fattening of the population pyramid, moving away from anything that really looks like a pyramid and looks more like a big fat doughboy. But really, you think about it. If you lived in an agricultural society, your children were resources for you, right? Need more hands to run the farm? Make some. Have some more children. In a knowledge economy, in an economy with specialized workforce, where people leave the household to go out to work, the children become a cost, and so poor people, poor communities, poor countries tend to have more children because they're useful, because they have a higher rate of childhood death, right? Whereas in the United States, most children, we have very, very low infant mortality. We have most children live past their first year, and then children really in a wealthy society, children move from being an economic asset where they are a productive asset to what I would call a consumption asset, which doesn't mean that you consume children. That's not what we do with them. What it means is we have children for the experience. We have children because that's part of being a person and having lived a full life is to have had children. And so we have children as for fulfillment purposes, not for economic purposes. If anything, children are a burden in a wealthy society. So as a result, people have relatively few of them because of the cost of raising them and of the cost of having the kind of experiences that wealthy people want to have with children. But there's a major challenge here, and that is with fewer people at the bottom of the pyramid, right? This is barely even pyramid shaped, but with fewer people at the bottom of the pyramid coming up, there are fewer people to provide long-term care in the home, which is something that historically human beings have always done, right? So we're going to have to rely much more on institutional structures to care for our elderly. And then there are fewer, traditionally some kind of middle elderly, if you will, were childcare providers, and that's not the case anymore. So the three largest countries in the world, I think we've talked about this previously, are China, the United States, and India. So obviously China and India are the two largest. China at they're very close. They're about 1.3 million. I'll show you that number in a minute. But you can see India has not reached the same level of condensation at the bottom as both the United States and China have. China really shouldn't have reached this point yet. They reached it because of government policy. India has not had population restriction type policies. And so this is a much more natural progression that you're seeing. And we'll come back to India in just a minute. But you can look at, for comparison to the United States, the European Union is much worse off than we are. They're much older and their populations are actually declining in many places. So like Italy, where my family's from, has negative population growth. So it's a very old country, as is much of Europe. And we can compare that to the population of some of the developing world countries, such as Nigeria. Nigeria is the sixth largest country in the world at 219 million people. And this is what you would expect to see more traditionally. So Nigeria is a up and coming country, lots of young people. Why is this good? Well, again, lots of young people coming up will be able to support the elderly. But also a young population is a more innovative population, right? So you got oldsters like me, in my 50s. I'm not going to be changing the world. It's you guys that are going to be changing the world, right? It's the people down here in the bottom that are going to change society. Us people up in the middle and toward the top, we're all burned out, and kind of useless. And primarily here, at this point, just consuming. But we're not going to change the world. It's going to be you guys that change the world. And so countries like Nigeria and other developing nations that have this more traditional pyramid are going to be a lot more dynamic economically. So I just kind of made the point about China and India being the two largest countries in the world. The US is the third largest country in the world. And you can see there's a dramatic drop off from India to the US, but India and China are almost the same. So about 40% of the world's population fits into the three most populous countries. It's important to think about this because if you recognize the sheer weight of the population of China and India in the world, we want to think about, if we're thinking about global health, you can't not think about China and India. And so, as you know, I regularly reference back to economic issues because my background. And I want to show you, so, right from the get-go, we've been talking about GDP and the connection between income and health. And so you can see from 1960 up through the 90s, right, the early 90s, India and China were, really no other way to say it, is grindingly poor, right? People were dying of starvation during this period in both countries. That was what it was. Now, both countries in the early 90s went through a period of economic liberalization. And as a result, both China and India have been growing at a incredibly rapid rate. China really outstripping India. And we could discuss why that is, but let's just leave it at that. That's a whole other course. But the reality is China is growing at an incredible rate. And really, if even and setting aside China, just looking at this growth rate would be really impressive, considering their baseline. But China, really an incredible rate. And China today has more billionaires than the United States does, never mind millionaires. And so this growth of economic resources comes with an overall improvement in health, right? Those basic determinants of health, like having enough food to eat, having shelter, are things that are a real challenge when you're existing at this level of income, right back here. But as you move into this kind of middle income state, many of the challenges of profound and destitution begin to go away, and we begin to see real potential for health. Now, to put China and India in context of the United States, this is the United States GDP per capita. And so you can see they've still got a long way to go to catch up with us. The US is still a far wealthier country than either on a per capita basis. And again, we've looked at wealth, in quintiles. So that averages don't tell you the whole story. But your lifetime, much of my lifetime, I was born back in 1970. So back here, right through till today, we've mostly been able to ignore China and India, most of my lifetime because they were so poor. But in your lifetime, they're going to play a major role in economics and everything, economics and culture, which is all intertwined, right? So it's all intertwined. And so your lives, your economic lives, and as well as health are going to be impacted by the emergence of China and India as global powers. So as China approaches the U.S. in terms of size of the economy, we're going to see their citizens seeking more parity in terms of health. So one of the things, for example, that we've seen with the rise in income in China is a demand for more meat, right? And so China buys a lot of meat from the United States. So that's an interesting thing. They buy large quantities of chicken feet. Apparently, that's a big thing in China. And if you doubt me, I can find an article on it. It's pretty interesting because we have a thing for chicken wings, and so to get 2 wings, you get 2 feet. So one of the ways that companies are profitable, meat packers are profitable, is they're able to sell the feet to the Chinese market. But one question to ask is, if we're so much wealthier than China and India, why don't we have more health? So I'll circle back to that in a minute. But one of the things that we need to think about is our debt, right? So in the United States, again, I set this at around the time I was born, just because it's my primary reference point, but this is the amount of debt that the U.S. federal government had, right, divided by GDP. So the amount of debt that the federal government held divided by the total amount of income that the country earned in any given year. And so you can see we were cruising along below 40%. Come the 80s, Reagan, we really ramped up our defense spending against in competition with the old Soviet Union. The Soviet Union collapses right about here, but then we have a bit of a recession. We're supposed to get a peace dividend. We do sort of, but we see a continued rise in government spending relative to the amount of taxes that we're bringing in. And then that gets a bit under control, through we have some growth. We have a fair amount of growth in the 90s. The 90s was a real hot period of time. We had, of course, 9/11 had a major impact on the economy. And then the housing meltdown and the Great Recession that you guys probably remember growing up, right? We spent an awful lot of money trying to kind of subsidize the economy. And that led to deep deficits. So a deficit is different than a debt. A deficit is, in any given year, how much money does the government spend versus how much money does it bring in taxes. The deficit is the difference when the government spends more in a given year than it brings in taxes. The debt is the cumulative effect of all the deficits added up. So if you spend more than you earn in one year, that begins to pile up your debt. And then the next year, if you don't pay it off, but you instead borrow even more money, your debt just keeps getting bigger and bigger and bigger. And that's what that's what our federal government has been doing. Is, in your lifetime, right? So you guys were mostly born kind of in this window. Basically, we've seen a straight line rise in debt since you were born, to now where kind of the magical turning point is this 100% of GDP, where now with COVID, we've seen a huge spike in deficit spending. This is thanks to both the Trump and Biden administration's approaches to sending out checks to try to spur on the economy. Why do I show you this? Well, for a number of reasons. Back here, when we had relatively low debt, or even here, which felt like it was really high, but it really was nothing compared to where we are today. Our ability to borrow when we run into problems is really crucial for national security. And so maybe, for those of you who are really concerned about, for example, climate change, one way that we can deal with climate change is spend a lot of money to fix things, right? But if we've already spent all our money by sending out checks to people so that they can go buy chicken wings or whatever else it is they were going to do with that money, we don't have the capacity to borrow to fix major issues like things that might come up as a result of climate change, like trying to improve seawalls, for example. So that's a major concern for you. You guys are going to have to live with this mess that my generation and the generation prior to me have created. This is a real problem, and it has real impacts on potential health issues for the future. So focusing in on 2020 specifically, this is from the CBO, Congressional Budget Office. So this is not some crazy libertarian kind of thing. This is right out of the government. You can check out the report here. It's a nice little report. But in 2020, we spent $6.6 trillion, right? And we brought in $3.4 trillion in revenues from various taxes. And they have a nice breakdown of where the money comes from if you click through to the site. And what I want to point out here is we spent $1.2 trillion on Medicare and Medicaid. If you add on Social Security for all our social spending, kind of broadly all our social spending, it's like $2.3 trillion. And traditionally what we would do is compare social spending to defense, because people would say things like, well, do we really want to spend, how much, we're spending so much money on, buying guns, and we should be taking care of our people instead. Well, now we spend somewhere in the vicinity of 3 times as much on social spending, mostly for the elderly, than we do on defense. And, my perspective is defense is one of the major functions of the federal government, as defined in the Constitution. And I'm concerned about that. But also to the point, going back to the graphics we were just looking at about the change in demographics, right, with an expanding elderly, you ain't seen nothing yet, as they might say, right? Because the bubble of elderly that are moving through our society is just going to get worse in the in the time through your 20s, 30s, and into your 40s. People like me are gonna have to retire, right? I mean, I plan to work till I'm about 70, but that's another 20 years. But all your grandparents and maybe some of your parents are a little older than me, right? All those people are going to be retiring, and they're going to become beneficiaries of Medicare and probably Medicaid, because of the lack of forward planning for care, right? We talked just a minute ago about, fewer people, fewer young people to take care of the old people means more institutional care for elderly, which means that, and what we know is much of the institutional care for the elderly is paid for by Medicaid. So all of this is just going to keep getting bigger and bigger in your lifetime. So not only are you currently, right, inheriting this situation of incredible debt, but we're going to saddle you with the costs of care for all those elderly that are coming up through that pyramid, right, that we were just looking at. So this has real impact in terms of your ability to finance kind of the basic delivery of care, but also to respond to important changes in the world, like climate change, which is real. I happen to think it's real. And I think the best way to be prepared for that is to have a lot of money available to try to fix things, because I don't see our politicians responding in a timely manner to it, because they tend not to. So what do I see continuing to happen as a result of the combination of debt and increasing deficits? Well, I see continued pressure on federal payments, right? So when I'm talking about federal payments, I'm talking about Medicare and Medicaid. We've seen that. We've talked about how in the healthcare delivery system, right, hospitals and physician practices are becoming more and more reliant on Medicare and Medicaid. Larger percentage of their revenues come from Medicare and Medicaid. So we're going to see the share of funding coming from the federal government continue to grow as a share in healthcare delivery, driven by an aging population. We're going to see continued, there's an awful lot of pressure when you keep hearing from the Elizabeth Warrens and so forth of the world saying we need, and the Bernie Sanders types saying we need, single payer. Well, that would be a massive entitlement growth, and we're already seeing this enormous portion of our federal budget is being consumed by spending on those benefits. And so if that happens, and I think it's going to continue to grow to some degree, your book kind of bemoaned the fact that it wouldn't happen. I think it's going to happen more. We've seen Medicaid expansion. I think that'll keep on. I think there's going to be a lot of pressure to keep that happening. But the problem there is that we're going to run out of money. And I think, this is not a surprise. We have known this demographic crunch was going to be coming since I was your age, since I was younger than you. I've been hearing about this since I was younger than you. So we've literally known about this for 30, 40 years. People have been looking into the future. People have been talking about this. People have been talking about what are we going to do about Medicare, Medicaid, and Social Security, in 2020, 2030, literally since the 80s. And they haven't done anything, frankly, is what the answer is. They haven't done anything other than actually increase the benefit. And so we're going to, politicians, like we talked about last time, from a public choice perspective, right, don't have an incentive to work in the long run. They're not stupid, right? That's not to say politicians don't understand the problem. It is that their incentive is to get reelected. And if they want to get reelected, they'd have to make hard choices, like things like cutting the Medicare program, cutting the Medicaid program, cutting Social Security. That would not be popular. Or reducing the benefits, right? Or forcing people on Medicare to use managed care instead of the fee-for-service Medicare. That's not a popular thing to do. And if you want to get reelected, you have to do the popular thing. And so we just keep kicking the can down the road. And it isn't like, choose your president from the past 30 years didn't understand that this was coming and that this was a problem. What they did understand was if they wanted to stay in office, they had to pretend like it wasn't. Well, at some point, we're going to run out of time. And it looks to me like that is going to happen on your watch. So what else? Well, this continued pressure is going to keep pushing us in the private sector in particular into HMOs and high deductible health plans, HDHPs, right? And we've talked lots about HMOs, and your book talks lots about HMOs. I just want to hit on what I'm seeing from my conversations in the field with providers who are dealing with people who have HDHPs. I actually think this is a good thing, and it's coming about as a result of that economic pressure. But if you have a HDHP, that means you've got, a $7,000, $8,000, $10,000 deductible before your insurance company starts kicking in on non-preventive medicine stuff. So you get your free birth control, your free mammogram, your free annual physical. But if you want to go see your primary care provider, that's $50, $100, right? That's what an HDHP is like. Right. And you've got to ring up that deductible up to $8,000, $10,000. What does that do? Well, in low deductible health plans, it used to be, you'd have like $1,000 deductible. You could burn that up in no time. And what that did was it insulated you from the rising costs of individual services. So if your doctor said, hey, you know what, I need you to go get this scan, you didn't really care where you were going to go because you were only going to pay $20, $50, something like that. Maybe you hit, a couple $100, and then you hit your deductible, and then the insurance company would kick in. And so you didn't really care that much about how much the providers were charging for their various services that they were directing you to. High deductible plans force you to reconcile with that, and on an immediate basis. So one of the things that health insurance does is it particularly with these low deductible plans, is you pay a lot of money with a low deductible plan in your premiums, but then whenever you access care, you don't pay very much money. With a high deductible plan, it's the reverse. You pay a relatively low premium, but you pay a lot for each of the care, each episode of care that you have. And so that makes you much more conscious of the cost of the individual episodes of care. Now, the good news with that, the bad news with that is it exposes you to some direct pain. The good news is that direct pain is a really strong incentive for patients to start to pay attention to how much they're being charged for the care that they are accessing, and that is resulting in patients demanding lower cost treatments or demanding to providers direct them to other providers that charge less. So instead of getting my MRI at the hospital where they're going to charge me $2,000 for the MRI, I'm now saying to my provider or my insurance company for that matter, where can I get it cheaper? And the insurance company, or, if your provider smart, your primary care provider smart, will say, well, the hospital will charge you $2,000, but the imaging center, the standalone imaging center downtown, they'll charge you $500. And you're saying, as a patient, you are self-directing to the lower cost centers. And what that results in is a continued shift away from the high cost hospital setting to the low cost outpatient settings. What does that do? That continues to make hospitals shut down and consolidate. So I think HDHPs are a good thing. I think we've been living in an illusion for a long time. And I think, it's a good thing. And I think we'll see some cost control coming as a result of the shift towards HDHPs. HMOs already control you. So they already direct you very tightly to where they want you to go. So that's a good innovation too. So if we could get more people into either an HMO or an HDHP, I think we would see some of the benefits that we're hoping for. That continued economic pressure, like I said, is going to have an impact on the health systems, and we're going to continue to see health system consolidation. One of the things we've talked about, when we talked about mergers and acquisitions, is just how many hospitals in New Hampshire alone have consolidated into systems. I think we're going to just keep on seeing that. I wouldn't be surprised if 5 years from now, there were only 3 health systems in the state of New Hampshire. We're already closing in on that. I would see a Dartmouth Hitchcock centered system, a Mass General system centered system, and maybe something with the new System Health. I forget what they call themselves, the one with Elliott and Southern New Hampshire. I mean, I wouldn't be surprised. Maybe they consolidate with the North Country Healthcare up in the north, something like that. We definitely have down to our south, we have Beth Israel Lahey, which is creating a system to compete with the Mass General Brigham. They'll probably acquire anybody else. So it could be, that could wind up being the system is, those could be the three systems: Mass General Brigham, Beth Israel Lahey, and Dartmouth Hitchcock owning all of the hospitals in the state. That wouldn't surprise me one bit. And I see that, in your lifetime, I see a likelihood that, most healthcare providers will be part of a monstrous system like an HCA, right? That's the for-profit healthcare system that owns Portsmouth Regional, Parkland Medical Center in Derry, as well as Frisbee in Rochester. There are systems like that in the country now that own 100, 200 hospitals. I would see that as, in the long term, I would see that as the future of health systems in the United States. It would probably be down to 8 or 10, national health systems. So that's kind of the system level. I would say one of the lessons that hopefully you'll take from this course is healthcare is expensive, but health is relatively cheap. And I know a bunch of you are nutrition folks and related fields. The growth in healthcare expenditures is driven in large part by chronic conditions, right? We do a lousy job of taking care of ourselves. And frankly, that's kind of a first world problem, right? Going back to the slide I showed you a minute ago, comparing the, relative wealth of the United States to the relative wealth of China and India, right? First world problem is too much abundance. We were not evolved, right? Because we're not that far from our evolutionary state, right? Homo sapiens have been around for about 100,000 years. We've been living in cities for only, the first city appeared about 10,000 years ago. And we've really only been living in cities, like the bulk of population living in cities for 150 years, up until now. The vast, up until 100, until the Industrial Revolution, which was when the population started to shift from rural to city living. The behavior, so we're talking about, in evolutionary in evolutionary scale, the society that we know and live in is the blink of an eye old, and our bodies were evolved to live in circumstances of scarcity, of incredible grinding, poverty. We can argue about, about that in terms of what hunter-gatherer, lifestyle is about. But the fact of the matter is, hunter-gatherers, if there was a bad season, they died. That was the end of the, that's the end. That's all she wrote. Today, that's not happen. That doesn't happen. Today, our main problem is calories are too cheap, right? You can go get 1,000 calories worth of cheeseburgers and French fries, for $5 at McDonald's, right? $5. That's like, if you were working minimum wage, that's like 45 minutes of work, and you can get, nearly a day's calories for 45 minutes of work. Hunter-gatherers would have spent most of the day trying to generate 1,000 calories. So the fact that we are fat and we don't exercise much, right, is directly related to just how wealthy we are. And that drives chronic conditions. Our bodies are designed to walk up, 20 miles a day, to eat very limited amounts of fat and sugar, and mostly live off of plants, right? And today's diet is mostly fat and sugar and protein, instead of living on complex carbohydrates coming from plants. And you nutrition folks can, run circles on me on this, but this is pretty simple stuff, right? Our bodies were evolved to eat plants, mostly plants, with a little bit of meat every now and then. Today, what we we mostly eat, refined carbohydrates, um, fatty meats, and lots of sugar. And as a result, we are, less healthy than we could potentially be. I mean, my favorite thing is a pint of Ben and Jerry's, um, uh, uh, Cherry Garcia, my favorite. And man, I could sit down and eat that thing in about 10 minutes, and it's the perfect evolutionary bomb, right? It is fat and sugar and nothing else in there. And it's just, it's literally like death in a can. Um, so we could fix a lot of our health spend is a result of chronic conditions. It's the result of, frankly, being too wealthy, right, and not having adapted to the reality that we are as wealthy as we are, that calories are as cheap as they are. And so, really it would be pretty simple because health can be improved by patients changing their health behaviors. But I mean, you guys are young, so you probably haven't had to try to diet, but I've been fighting weight, now for 15, 20 years. So like you hit 30 and really just everything kind of goes to pot. I'm afraid to tell you, and I retired from the Army in 2015. I weighed 170 pounds, and 6 months ago I weighed 204. So I put on 35 pounds. I've been dieting, trying to develop better behaviors, and I've lost about 10 pounds. So I'm like 195 pounds now. So 20 pounds heavier than when I was when I retired from the Army. I should, you guys have never seen me physically in person, I don't think, most of you. So I'm not a tall guy, so I should probably weigh about 170 pounds. That's good weight for me, right? But it's so easy and so pleasant to eat, a nice steak and then finish it off with a pint of Ben and Jerry's. Really hard to change that behavior because it's just so gratifying to my evolutionary, system that tells me, ooh, hey, that's sweet, that's good. We want some of that because, who knows when that'll come along again, right? So the question, the holy grail now is population health, and population health hinges on changing patients' behavior, and it's just not that easy. I had the Army Surgeon General was a boss of I had many years ago, and I remember hearing her talk at one of her first public appearances as the Army Surgeon General, and she gave this great talk that I remembered as more than 100 minutes. And her point was the average patient in the military health system accesses their provider 5 times a year for a 20-minute visit. And so basically, the health system's direct impact on the patient amounted to 100 minutes out of a whole year, which is an absurdly tiny percentage of your time in a year. And so her point was, how do we shape behavior if all we get is 100 minutes? And so I'm afraid to say, I don't think she's cracked the code yet. She's still working on it. She's retired now and doing some great stuff. But putting the burden on the healthcare system is not likely to result in an improvement in health. So population health is where it's at. That's the future. And what are we doing and talking about it? Well, one of the things we're talking about is this concept called patient activation. And patient activation basically is a way of looking at your patient and saying, how engaged is this patient with her or his own care? And so they've got this mechanism for rating, very low to very high. And ideally, what we want is everybody to be over here as their own healthcare advocate, right? And as a result, people who are their own healthcare advocate, which probably some of you guys, the nutrition people, who tend to be really healthy types. So I imagine most of you are over here. I'm probably somewhere, in here. I mean, I'm definitely not, saying I'm incapable. I'm well aware of what I need to do. I just don't do it to the degree that I should, right? So patient activation is a thing that you're hearing, particularly in the population health world. Providers are talking about, okay, how activated are my patients? And so we've got a cool little survey you can look at later. It basically just says, here's 10 points to try to evaluate how activated you are. One of the interesting things coming about as a result of social media is people are more connected than they once were, right? And I did a research project back a number of years ago, and I just looking at the role of social media in health. And one of the things I came across was this website called Patients Like Me, and it's out of Boston, it's headquartered out of Boston. It was developed by a couple of MIT engineers. And what they do is they're a community of lay people, so non-healthcare providers who have illnesses, right? So if you have cancer, you can sign up for Patients Like Me, and then you list your conditions, and you get put into communities, and you can interact with other people who have similar conditions to you. And what the goal of Patients Like Me is for people to share their stories and give each other advice, right? Oh, this worked for me. This didn't work for me. Oh, that meant, hey, you know what? You know, I see you're talking about these conditions. I had those, and my provider put me on, you know, blah, blah, blah medication, and that made all the difference. So that's to me kind of amazing, right? Like, this is a thing that could not have happened 10, 15 years ago. But in your lifetime is going to become normal, perfectly standard. But this requires, right, a fairly high level of activation. And so there's a clear connection between activation and, you know, communities of people building around their health. And so Patients Like Me is a tool that activated patients can use to try to improve their outcomes. And there's some good evidence that the advice that you get from these kinds of sites can actually be quite good. And that's kind of amazing. So if you wind up with a chronic illness, you might check out Patients Like Me. You might find useful information there for you. I don't wish that on you. I hope you don't get it. Now, one of the amazing things that's coming, that's happening now, that we're working on, is this idea of personalized or precision medicine. And this is a result of the interface or intersection between pharmacy and genetics. So we've, you know, Moderna and Pfizer had, you know, using the genetics, the genetic code that they got from the Chinese government on COVID, you know, had a functioning, specialized immunization, vaccine within 48 hours of getting the information, of getting the genetic code. That's an amazing example of precision medicine, right? But now we're even looking beyond, you know, a rapid creation of medicines that are specialized to particular illnesses. We're looking at aligning drugs with individuals, right? And what personalized medicine really will do is we've for a long time have known that some medications work on some patients and not on others. Some medications patients respond to well, and other patients don't respond well to the same exact medication. And so what we are able to do as we start to understand the interaction between pharmacy and genetics is we can arrive at the ability to predict, oh, based on your genetic code, this drug is not going to work for you. It'll work for somebody else, but not for you, right? Instead, what we need to give you is this other drug, right, that works for people who have a genetic code like yours. What that means is, you know, looking back on old clinical trials, we've talked about the cost of clinical trials as being, you know, close to $1 billion to bring a new medicine to market. That means probably that many of the drugs that failed, that showed some initial possibility, maybe really were perfectly good. They just were used on a mixed population where some of the people weren't going to respond to it because of their genetics, and other people did respond to it. So now companies are going back and saying, let's start to look at the genetic interaction here, and these failed drugs are coming back instead being said, hey, you just use it on this particular kind of patient. So this idea of predictiveness, so this personalized medicine is really coming about as a result of increased computing capability, and it's enabling predictiveness. So I want to talk about AI and machine learning, right, which are really kind of the same thing. I don't know. I'm not a computer guy, so for me, they're very similar. I mean, AI kind of gives me this sense of like some sort of independent entity. Spooks me a little bit. Machine learning makes me feel a little safer. But to me, this is the key to population health, right? We're going to combine increasing computing power and computing ability to population health. We're going to be able to take, the genetic information combined with all of your information coming out of your EHR, and a computer is going to be able to process all that information and see patterns that human beings just never would be able to achieve. And that's what machine learning is it takes data and it uses tools that are beyond traditional statistical tools that we have used, doing social science and biological science, right, for for 100 years. Machine learning just goes way past that and can see and develop algorithms that are based on patterns that we just wouldn't have had the capability of doing 5 years ago. And that's only going to continue to increase. So the benefits, right, that are coming from personalized medicine are just going to keep on coming, and they're going to get more and more powerful. And the key to population health, of course, is large scale, which is another reason why we're going to continue to see consolidation in the healthcare delivery system. Is, in order to achieve large scale learning, we're going to need large populations, and machine learning and AI are not cheap. And so in order to achieve that, we're going to have to consolidate and have, these capabilities at centralized points. So, when we have Mass General now has, 10 million lives under it, then, Mass General can afford to build the infrastructure of machine learning and start to predict and find the patterns and start to predict which individuals will require what kind of care. So running with AI is transhumanism, which we've talked, you watched the video on a bit, and talking about like, what's the difference between supplementing and actually like becoming a cyborg. I mean, and Hugh Hare, the scientist that gives the talk, kind of indicates it's when we cease to think of the technology as separate from ourselves. And he gives the example of his friend whose leg he controls basically through thought, because his friend thinks about moving his foot, that causes his muscles to move, his residual muscles to move, and they've rigged up sensors to be able to detect that residual movement. I'd say, that's a cool, really cool thing. But I think in the future, we'll have something where it's probably wired right into your brain, and it'll cease to have that physical difference. It's exciting. Transhumanism is, this idea that we're going to integrate with machines, with supplements. And I think, beyond the very, to me, mechanical example that the video that we watched had, I'd say, think about cochlear implants, right? That's where we've talked about those in a previous lecture. That's an implant that's integrated into the person's experience. You don't think about the cochlear implant separate from you. The cochlear implant is part of you. So you can think of that as kind of cyborg hearing. And we've got, in development, we've got artificial pancreases and so forth that will end diabetes, right? And so I see a future where, we are going to have more and more machinery integrating with human beings as part of that health continuum. Some things are kind of, this idea of back to the future that I've talked about a few times. Something that I've become aware of relatively recently is a resurgence in psychedelic research. Now, you could say we've had psychedelics in human history for millennia. They've traditionally been part of some religious treatments, concepts, and we LSD was first, I want to say it was in the 60s, was lab created, and it just ran headlong into culture wars of the 60s and 70s. And so was banned, right? It made it illegal and banned for a long time. And we have naturally occurring psychedelics as well, of course. But it ran headlong into the cultural clashes of the 60s and 70s and was basically, ruled out. You couldn't, even if you wanted to do research on it, legitimate research on it, you couldn't get access to you couldn't legally, of course you can get access to LSD. Anybody can, but illegally you can get access to it. But if you're trying to do, scientific research, you can't say, well, I went, down to the dark street corner down in Boston and picked me up some samples from my lab. That's not going to fly, right? So basically the anti psychedelic cultural response, made it illegal to do that research for a number of decades, and only relatively recently has psychedelic research returned. And what's emerging is psychedelics given under the control and controlled administration of psychiatrists and other trained professionals can have profound curative effects on chronic anxiety and chronic depression. These are just the early stages of this are miraculous. Now, I share this with you, not just to be like woo-woo because you guys are in college, but because this is a great demonstration of the interface between medicine and culture, right? And so, the cultural clash really rejected these potential treatments for a number of decades, and it's a shame because it looks like we have real potential here. And so my last item I want to share is I was on the Mass Eye website, Mass Eye and Ear, which is a specialty hospital down in Boston, in case you're not aware of it, that specializes in eyes and ears, hence the name, right? So it's a otolaryngology and ophthalmology specialty hospital. So it specializes in eyes, ears, nose, and throats. And I was bumping around on their website looking for some information, and I bumped into this page, and I was just fascinated, right? One of the things they're offering is plastic surgery to help, in particular, trans women, males who have transitioned to women, to have their faces changed. And this is now, right? Like, this is not a prediction. This is really happening. And I want to leave you with, kind of my last thought in terms of the future is we're going to see more of this, right? So this is basic, but we're going to see more of this. And this is kind of my last example of how culture and health interact. And I want to circle back to our early chapters as we talked about health and what is health. Health is more than an absence of disease. It's about achieving a state of well-being. And so for people who don't feel like they were born into the right gender, services like this are going to help them find their way to a better state of well-being. And that's a good thing to me, because I think a good health system partners with its patients to help them live their best lives, and it certainly doesn't judge them. So closing thought. This course is called U.S. Healthcare Systems. Your book is Delivering Healthcare in America, and I showed you these two pictures back in the very first lecture, and I said, does the US have a health system? And one view of a system would be the watch, right? So that's the internal workings of a watch on the left. Another way to look at a system is an organic system. And if you imagine the US healthcare, and you have in your mind a system is like a watch that can be fine-tuned, that can be directed, that can be understood and taken apart and rebuilt, then no, the US does not have a healthcare system. We are a highly dysfunctional, from that paradigm, we're a highly dysfunctional mess of services and cultural beliefs. That's just, just a dysfunctional. But if instead you look at the United States health system, or if you hold in your mind the idea of a system as an organic thing that evolves, then I think yes. I think yes. I think it's imperfect, and it's constantly changing. But I think if you think of the U.S. healthcare system, which I do think we have, as something like a coral reef, that instead of being controlled and tooled and taken apart by smart people, if instead you can think of it as a system that has to be nurtured and cared for and protected and not forced, then I think that you can see, just how remarkable it is. Not perfect. It doesn't accomplish everything that we'd like it to, but it's a remarkable, remarkable system. And I would say further, this is me speaking, last thoughts as an economist. Human systems, the economy, are always better to be thought of as more like reefs, coral reefs, or forests or jungles, right? Than they are like watches. That isn't how human beings function. You can't force a human being to become something that he or she doesn't want to become. You can't force a society as a result to become a thing that it doesn't want to become. So, and where you've seen that attempted, communist China, Venezuela, Eastern Germany, the Soviet Union, you see that accompanied anytime you have this kind of thought that that smart people can force a system on a community, you always wind up seeing misery and suffering. Instead, I think the right approach to human systems and to working with human beings is to treat them with dignity and respect, um, and to remember that they are organic beings, and good policy, good government, which I've talked a lot about, right? I do believe there's an important role for government, even though I've bashed it a lot. But good government is nurturing and not directing, right? It is caring and protective, but doesn't try to use force. All right. Well, I hope you've enjoyed this course, and I hope you've gotten a lot out of it. I look forward to hearing from you, and feel free to come by and visit in the fall.